This conference will now be recorded.
Welcome, everybody. My name is Susan Hayes, and I work for the Oklahoma State Department of Health. I'm a clinical health facility surveyor 3 and have been for 10 years. I've been working in the training department, training our surveyors for the last 3. And so today we're going to talk a little bit about admissions, transfers, and discharge rights. And these are the tags that are from 620 to 626. So our 620 is the admission policy, and all facilities should have an admission policy. This was written no times in 2019. There's usually not an issue with the policies, the admission policies in the facilities. This says that the facility must not require residents or potential residents to waive or limit their rights to Medicare or Medicaid. They cannot request or require oral and written assurance that residents or potential residents are not eligible for and will not apply for Medicare or Medicaid. If they are eligible, then they need to be able to be given that right. The facility must not request or require a third-party guarantee of payment to the facility as a condition of admission or expedited admission or continued stay in the facility. You cannot require that the family is going to pay for this stay. You can visit with the family if they have control of the money to put up a deposit possibly and to make sure that they are going to take care of the bill, but they are not to be required to use any of their personal money to pay for these stays. The facility must not request or require residents or potential residents to waive potential facility liability for losses of personal property. This is a big one that's changed, that CMS changed whenever they brought out the new tags in 2017. This does not mean that the facility has to pay for everything that is lost. If the resident has a $10,000 ring and the facility has made sure that that family understands that there is a potential that that ring may be lost and they choose to leave it with the resident, that does not necessarily mean that the facility has to pay for that $10,000 ring. But they do need to take care of anything that they possibly could have been responsible for destroying, such as furniture, or let's say that one of your staff accidentally stepped on the resident's glasses, or they were the ones that dropped the dentures in the floor and broke them, then the facility probably will need to assume those liabilities. The nursing facility must disclose notice of special characteristics or service limitations prior to admission. If you have a designated Alzheimer's unit that is locked, then you need to make sure that the facility is aware of this, or if you have any other special units, you need to make sure that the residents or their families are aware of these. They also need to be aware if you have any limitations to what kind of care you can provide. If they're wanting to bring a resident in on a ventilator and you don't handle ventilators, you need to make sure they understand this. If a resident has the potential to have massive wounds and the physician could possibly prescribe a piece of equipment to handle these wounds that your facility is not familiar with, they need to understand that. A nursing facility that's a composite distinct part must disclose in its admission agreement its physical configuration, including the various locations that comprise the composite distinct part, and must specify the policies that apply to room changes between its different locations. I don't believe at this point in time that we have any nursing facilities in the state of Oklahoma that are composite distinct part defined. So we're not going to worry about that at the moment. In the case of a person eligible for Medicaid, a nursing facility must not charge, solicit, accept, or receive, in addition to any amount otherwise required to be paid under the state plan, any gift, money, donation, or other consideration as a precondition of admission, expedited admission, or continued stay in the facility. Note, a resident cannot be discharged for non-payment while their Medicaid eligibility is pending. So Oklahoma state licensure basically mirrors the federal requirements for admissions, discharges, and transfers. And you can look in Chapter 675 under Subchapter 7 of the Nursing Home Care Act for all those details specific to the state of Oklahoma. Like I said, most of those pretty much fall right in line with the federal regs, so there shouldn't be a whole lot different there. One thing I want you to think about, and if you take nothing else away from this training today, I want you to please remember, before you admit a resident, you need to take the time to do a pre-admission screening. An ounce of prevention is worth a pound of cure. Once you accept that resident and they are in your facility that is now considered their home, and it basically, I'm just going to put it this way, it basically takes an act of Congress for you to be able to discharge this resident. They are yours, they are your responsibility, and you need to make sure that this resident is going to fit in with your facility. You do have the right to deny admission to any residents, but you need to be sure that you're not denying admission because of race, religion, those types of situations. So 621 is the equal access to quality care. Once again, this was not written in 2019. And what does this mean? Well, this means that all the facilities must treat all the residents alike when they're making transfer and discharge decisions. If the nursing services such as rehab, social services, dietary, pharmaceutical, or activities that are mandated by law must be provided to all the residents according to their individual needs as determined by their assessments and their care plans. They must establish, maintain, and implement identical policies and practices, regardless of the transfer and discharge and the provision of services for all individuals, regardless of the source payment. So you can't offer your SNF residents a whole lot better care than you offer your long-term care residents. The facility may charge any amount for services furnished to non-Medicaid residents unless otherwise stated, limited by state law and consistent with the notice requirement. This is why facilities like private pays, because you can charge any amount for those services. The state is not required to offer additional services on behalf of a resident other than services provided in the state plan. If the state plan, if Medicaid does not offer a service, then the facility does not have to offer that service. However, you may want to think about some of the things. If the state plan is not going to offer occupational therapy, then you might think about possibly getting an occupational therapy consult to design some exercises for a resident. Room changes in the composite distinct part must be limited to moves within that particular building which the resident resides, unless they voluntarily agree to move. Once again, we don't have a composite distinct part, so don't have to necessarily worry about that. So let's move on to our transfer and discharge rights. The definitions. Transfers and discharge include movement of a resident to a bed outside of the certified facility, whether it's in the same physical plan or not. Transfer and discharge does not refer to movement of a resident to a bed within the same certified facility. So if all you're doing is moving a resident from room to room, that is not considered a transfer. If you're moving them from your facility to the hospital, from your facility to another facility, from your facility to a jury psych facility, that's a transfer. If you're moving and a discharge. So there are, CMS actually put together some definitions for the differences between a facility-initiated transfer or discharge and a resident-initiated transfer or discharge. The resident-initiated is the resident or the family has decided that they want this resident transferred or discharged to another facility or to home. And these are not part of what any of these regs pertain to. The facility initiated transfers and discharges when the facility has decided the resident needs to go outside the building to the hospital, outside to a geropsych unit, that they have met all their goals and they're ready to be home. Then they are considered a facility initiated. The facility initiated are the ones that we're going to be discussing in all of these transfer and discharge right tags. So the regulations apply to transfer and discharges that are initiated by the facility, just like I said. The transfer is moving a resident from the facility to another legally responsible institutional setting, and a discharge is moving the resident to a non-institutional setting when the releasing facility ceases to be responsible. The transfer and discharge provisions significantly restrict a facility's ability to transfer or discharge a resident once that resident has been admitted to the facilities. Remember, if you don't, once they're in your facility, you have a hard time discharging them or transferring them. So under F622 for discharge and transfer, the facility may not transfer or discharge a resident unless, and these are all very important things to know. Number one, transfer or discharge is necessary to meet the resident's welfare, and the resident's welfare cannot be met in the facility. The transfer or discharge is appropriate because the resident's health has improved sufficiently so the resident no longer needs the services provided by the facility. Number three, the safety of individuals in the facility is endangered. Number four, the health of individuals in the facility would otherwise be endangered. Number five, the resident has failed after reasonable and appropriate notice to pay for a stay at the facility. Or six, the facility ceases to operate. If you have given a discharge or a transfer notice to a resident and they choose to appeal that, then you are not allowed to transfer or discharge that resident unless the danger of the facility, the residents, or the individual is in danger, and you have to wait until the appeal is pending before you can actually discharge or transfer them. So when the facility transfers or discharges residents due to their needs not being met, or if they're a danger to themselves or others, we all know, you've seen, if you've been in the nursing home long enough or long-term care long enough, you know that we have residents that do have behaviors that do endanger themselves due to their behaviors, or they actually endanger the other residents in the facility. And when we talk in endangering, we're not just meaning physically endangering the others, but it could also be emotional. The facility must document the needs that can't be met. The facility attempts to meet those needs and the services available at the receiving facility to meet those needs. So you're going to have to try and do everything that you can to meet the needs of that resident. And if you can't, then you're going to have to make sure that the facility that you're sending them to will be able to. The physician must also document the need for the transfer. So besides you having documentation of why this resident needs to be transferred or discharged, the physician is also going to have to do this. And when we're talking about documentation, we're not talking about one incident. If a little resident has a temper tantrum and swings at one staff member, that is not enough to discharge or transfer that resident. Find out why that resident swung at that staff member. Watch and see if it happens again. Make sure that just one violation is not enough to discharge. Find out exactly why and see if you can't meet those needs. If the transfer is due to a significant change in condition, but it's not an emergency, then prior to any action, the facility must conduct the appropriate assessment to determine if a new care plan would allow the facility to meet the resident's needs. This goes back to that documentation. If you need to see if there's anything that you can do, reassess this resident, look at the care plan. What else can we do to meet their needs so that we don't have to discharge them? Conversion from a private pay rate to Medicaid rate does not constitute non-payment. So you need to think about that whenever they've been private pay, all their money's run out, and now they're having to apply for Medicaid. You cannot consider that non-payment until the Medicaid has actually denied. Refusal of treatment would not constitute grounds for transfer unless the facility is unable to meet the needs of the resident or protect the health and safety of others. Residents have a right to refuse treatment. For example, one facility had a little gentleman. He was a dialysis resident. He decided he was not going to go to dialysis anymore. It was too early, and he didn't want to take his meds when he came back, and he just decided he wasn't going to go anymore. And all the facility needed to do was try and change his time, and then maybe that would have helped him actually accept his treatments. Documentation of the transfer and discharge may be completed by a physician extender unless prohibited by state. I believe our state does allow that documentation by the PAs or the nurse practitioners. So let's just look at a couple of examples of 622 that were written in 2019. And this tag was written 14 times. The resident voluntarily discharged from the facility without appropriate cause because the resident would refuse dialysis and medications. Dialysis because his appointment was too early, and medications because he was too tired to take them after dialysis. He was sent to the hospital with the intent to return, but the facility refused return of resident and discharged him. If they would have just talked with this little resident, his appointment, he had to be up and around at 4:30 every morning so that he could make his appointment at 6 o'clock. And he was not a morning person to begin with. If they had just looked at what they could have done to try and change his time at the dialysis center, probably all of his refusals would have stopped. You cannot involuntarily discharge a resident without appropriate cause due to refusal of care is not an acceptable reason for discharge. No physician documentation of the reason for a resident's involuntary discharge from the facility. Not only should there be lots and lots of facility documentation of why this resident's involuntary discharge was necessary, but there also should be lots of documentation from your physician. The medical record revealed the resident was being discharged to the geriatric psych unit. The physician did not document a reason for this discharge, and the administrator stated she didn't know the physician had to do this. Okay, guys, you as an administrator, I'm telling you, physician needs to document why this resident's discharge was necessary. This was actually written. Once again, it's important. Before admitting a resident, take the time to do a pre-admission screening. It won't be the last time you see this. I'm just telling you, take this away as gospel. Please go and see these residents, look at their charts, visit with the staff. If another facility is trying to called you for a transfer, there's probably a reason why they're trying to transfer this resident out of their facility. So it would behoove you to go and see exactly what's going on and do a pre-admission screening before you allow them in your facility. So 623 is the notice before transfer. This also was written 14 times in 2019. A lot of times you will see when 622 is written, this one is also written because in order to actually transfer or discharge a resident, they have to give a notice. The facility must notify the resident and the representative with reasons for the transfer or discharge in writing and in a language they can understand within 30 days of the transfer and discharge. except when individuals in the facility would be endangered, the resident's health improved significantly so they no longer need the services, the immediate transfer was required for urgent care, or the resident had not resided in the facility for 30 days. If you're going to transfer the resident to another facility, or you haven't found a facility that would take him and you're planning on discharging them to go home, you have to give them and their representatives a 30-day notice. This notice must contain reason for the transfer and the discharge. Spell it out for them. Exactly why are you discharging or transferring this resident? The effective date of the transfer or discharge. The location to be transferred or discharged to. Where are you sending this resident? The statement of the resident's appeal rights, including contact information. The ombudsman contact information. The contact information for the advocacy group for the IID residents if needed, and the contact information for advocacy group for mentally ill residents if needed. All of this should be on your form. Most facilities already have a template that they use for everyone with all of these pieces of information on there so that no dots are not dotted and no T's are not crossed. So these things must be on your notice. Now, the facility must notify the Ombudsman Office for any facility-initiated transfer or discharge as soon as possible. So this is a new piece that CMS put in. They must contact and send a copy of the 30-day notice to the Ombudsman Office at the same time they're giving it to the resident or representative. So whenever you're handing the resident their 30-day notice and you've contacted the family with theirs, you also must send and contact the Ombudsman Office. When the resident is transferred to an emergency basis, boy, I'm having trouble talking today, guys. A transfer notice must be provided to the resident and representative as soon as practicable. Now, this doesn't mean that you have to turn around and make sure that the ombudsman is notified that day. The facility can keep a running list of hospitalized residents over the month before they present it to the ombudsman office. So anybody that's transferred to the hospital, just keep a running list of all of those people because that is considered a transfer. And then you can just present the running list of the hospitalized residents at the end of the month. If the resident is hospitalized when the facility decides to discharge them, there's two different ways to discharge. You discharge with return anticipated and discharge with return not anticipated. If the resident is hospitalized when the facility decides to discharge them, the facility must send a copy of the notice to discharge to the resident and the representative. So you may have to actually hand carry a copy to the resident in the hospital if you all of a sudden decide that you're not going to readmit them, that you're wanting to give them a 30-day notice. In the case of a facility closure, the individual who's the administrator of the facility must provide written notification prior to the impending closure to the State Survey Agency, to OSDH, the Office of the State Long-Term Care Ombudsman, residents of the facility, and the resident representatives, as well as having a plan for the transfer and adequate relocation of the residents. So looking at 623 examples, the facility failed to present a written notice of discharge to a resident. Yep, that'll do it. If you didn't give them that 30-day notice and you didn't let them come back from the hospital, or you took them down and put them in the homeless shelter, though that's going to be a citation. The resident was involuntarily discharged. The social services director and the administrator stated they had not given the resident or his wife written notice of a discharge. Once again, there it is, no notice. Usually 623 is because the notices were not given or a piece of the notice was missing is usually why 623 is written. So 624, orientation for transfer or discharge. The facility must provide and document sufficient preparation and orientation to residents to ensure safe and orderly transfer or discharge from the facility. And this must be in a form the resident can understand. So if you're going to transfer a resident out to the hospital, then you need to visit with that resident if you're able to visit with them and let them know that they're going to go to the hospital. If you're going to discharge them from the facility, then you need to be talking with them. If you're discharging them to home, then you need to be giving them instructions on how to take their medicines, if they're going to need to get any lab work done, visiting with their doctors. All of those things must be given to the resident and in a way that they can understand. So sufficient preparation and orientation means the facility informs the resident where he or she is going and takes steps under its control to minimize anxiety. So that's the whole point of this tag, is to make sure that the resident's not anxious about the transfer or the discharge. Sometimes these residents, this is their home, and it's almost like moving to a new home, moving to a new house. We all know how anxious we are if we even move households. So you can imagine how they feel. So examples of this is no orientation for discharge to home. They failed to provide sufficient preparation and orientation for an involuntary discharge. And the facility failed to ensure residents' belongings were not left behind during a transfer from the facility. Lots of times they transfer and don't take all of their belongings. 625, notice of bed hold policy and readmission. This was written 4 times in 2019. The facility must provide notice of the bed hold and return policy before transfer and upon transfer. And the intent of this tag is to ensure that the residents are made aware of the facility's bed hold and reserve bed payment policy before and upon transfer to a hospital or when taking the therapeutic leave of absence from the facility. And basically the way most facilities have done, from what I've seen whenever I've been in the field, is in your admission packet, you have your bed hold policy and you bring that to their attention. And then whenever the resident is being transferred to the hospital or being transferred to the Jerry Psych unit or being discharged, then you give them the second notice. The nursing facility's bed hold policies applies to all the residents. You can't say, okay, if you're private pay, we'll hold your bed for 10 days and then you can come back to it. Everybody has to have the same bed hold policies. So for Medicaid funded residents in Oklahoma, it states that the nursing facility may receive payment for a maximum of 7 days of therapeutic leave per calendar year for each recipient to reserve the bed. No payment shall be made to a nursing facility for hospital leave. So when we're talking therapeutic leave, we're not talking hospital therapy. We're talking the family comes and gets them on a Friday night over Christmas weekend and brings them back on Sunday. Then that's the kind of therapeutic leave that we're talking about. They basically feel like if they have, excuse my dog, real world, if they have more than 7 days of therapeutic leave per calendar year, they probably don't even qualify to be in this nursing facility. And that's basically what it says here. Bed hold for days of absence in excess are considered non-covered services, and that means that the resident could use her own money to pay for that bed hold. If a resident does not elect to pay to hold the bed, readmission rights to the next available bed are specified. So if they decide that they're going to leave for a week and they don't want to pay for it, you don't have to bring them back to their same bed. They just have the readmission rights to come back into the next available bed that's available in the facility. Non-Medicaid residents may be requested to pay for all days of bed hold. So if you have a private pay resident, you can request that they pay for all days of their bed hold. So examples of this is the facility failed to provide written information regarding bed hold policies to the resident and or their representatives when transported to the hospital. So when we come into F626, permitting residents to return to the facility. This was written 2 times in 2019. A resident who hospitalized or therapeutic leave exceeded the bed hold period under the state plan returns to their previous room if available or immediately upon the first availability of a bed in a semi-private room if the resident requires the services of the facility and is eligible for Medicaid or NIF or SNF. Is not permitting the resident to return after hospitalization or therapeutic leave meets the requirements of a facility-initiated discharge and must be handled as such. So if you are going to not let this resident return after the hospital stay, or you're not going to let them return after a long therapeutic leave, then you now have to initiate the discharge, and you have to give them a 30-day notice, and you have to give them all the information that is required in that 30-day notice, and you have to handle it that way. A facility may have concerns about permitting a resident to return to the facility after a hospital stay due to the resident's clinical or behavior conditions at the time of the transfer. The facility must not evaluate the resident based on his or her condition when originally transferred to the hospital. Basically, what this is saying is for those little residents that you send off to the Jerry Psych ward that were having behaviors that you found unacceptable whenever you transferred them, you cannot decide while they're gone that, I'm not going to bring them back because they were just being horrible whenever they were here the last time. You have to actually admit them back into your facility. You do not have the right to say that they cannot come back. If the facility determines it will not be permitting the resident to return, the medical records should show evidence that the facility made efforts to meet the resident's needs. So if you're not going to let that little gentleman return back to the facility, you should have lots of documentation as to why your facility cannot meet the needs of that resident. So examples of this were the facility failed to allow a resident to return following therapeutic leave to a family member's house, resulting in the resident being found living on the street without food or shelter. The medical record did not contain evidence of a valid basis for discharge, and there was no evidence of discharge planning. This was cross-referenced, and it was also cited at 622 under transfer and discharge requirements and at 660 under discharge planning process. This actually resulted in an IJ citation. Another one, the facility failed to allow a resident to return to the nursing facility following a hospitalization that exceeded the bed hold policy and state plan. The facility discharged the resident on the basis of being unable to meet his needs. The survey team was able to verify that the facility had accepted residents with similar conditions during the time frame that the resident was ready to return. This resulted in the resident being sent to another facility which was in a location not easily accessible by the resident's family. The resident expressed feelings of depression and loneliness, and this resulted in actual harm. This is one of those where CMS is really starting to have surveyors really start looking at psychosocial harm, and that's probably where this actual harm came into, was the psychosocial because of the depression and the loneliness. So if you're going to tell a resident that they cannot come back to your facility because they have a wound vac and you're not capable of handling the wound vac, then you need to make sure that you don't admit somebody else that has a wound vac, because then that's playing favorites per se, I guess, but that is not acceptable. So one more time, before admitting a resident, take the time to do a pre-admission screening in person. You can all say that together. Before admitting a resident, take the time to do a pre-admission screening in person. That's probably all that I have at the moment. If you have any questions that I could possibly answer, and I'm sure there are a lot, we usually have lots of discussion over the discharges whenever I'm actually able to be present in class. So if you have any questions, if you'll just get them to Z, then he can send them my way, and I'll see if there's anything I can do to answer those for you. In the meantime, just take care and be safe. Thank you.